Good afternoon. I'm Tazeen. I'm from CBM Global Disability Inclusion, Bangladesh. Um, Thank you for inviting us. Thanks to Irish Global Health Network for accepting this abstract and give me the opportunity to share our work. Um, our presentation will be focused on how CBM Global, we are trying to develop an inclusive health model and contributing in Bangladesh. So I will go to my presentation. It's not working. Yeah, so at the beginning, we would like to share a few description about CBM Global Disability Inclusion. We are from CBM Global Disability Inclusion works alongside and is accountable to people with disabilities in the world's poorest places. We draw on more than 110 years experience to fight poverty, exclusion, and to transform lives. We work with the most marginalized people in their society to break the cycle of poverty and disability, treat and prevent conditions that lead to disability, build inclusive communities where everyone can enjoy their human rights and achieve their full potential. We try to maximize our impact by delivering a combination of inclusive community-based program, advocacy, inclusion advisory support to different stakeholders. Now, if we look into some facts on inclusive health and rehabilitation situation in Bangladesh, we have around 4.7 million persons with disabilities, which is 2.4% of the total population. The information we have received very recently from BBS. People with disabilities continue to experience stigmatization, discrimination, and inequalities in accessing health and rehabilitation services, having poorer health outcomes compared to people without disabilities. From one research that we have conducted few years back with one of our partners, we have found that in our working areas, 54% people with disabilities face barriers to receive mainstream health services from district and national level facilities. Only 22.8% of persons with disabilities accessed rehabilitation services, with a relative percentage highest in capital city, Dhaka. Now, if we look into some national and international policies and framework where we can find that there is huge reflection on inclusive health and rehabilitation, but unfortunately, the persons with disabilities, they cannot get health and rehabilitation services at country level. Article 25 and 26 of the Convention on the Rights of Persons with Disabilities, CRPD, obligate state parties to help people with disabilities attain the highest possible standard of health through the provision of health-related rehabilitation. Also, if we look into the SDG goal, the health goal 3 of SDG is comprehensive, which reflects healthy lives and promote well-being for all at all ages. Human health and well-being depend on the political, economic, and social systems and the natural environment within which people live. But unfortunately, our experience is that persons with disabilities hardly get health and rehabilitation support at their community level. The Rights and Protection Act of Persons with Disabilities 2013 of Bangladesh emphasizes persons with disabilities have the right to have the highest quality of health care on the basis of availability. These are some reflection from the national and international policies. Now, we move forward, that how we, from CBM, we try to develop a project focusing on inclusive health and rehabilitation services for persons with disabilities, with the support from our implementing partner, Disabled Rehabilitation and Research Association, DRRA. We conducted an evaluation in 2018 to determine the effectiveness, efficiency, and impact of the project. We followed the methodologies of desk research, individual interviews with program participants, observations of hospitals, community clinics, focus group discussions with organizations of persons with disabilities. We also undertook key informant interviews with government officials. Before going to the findings of the evaluation, we would share major interventions of this project. We try to actually work with the Ministry of Health and Family Planning in these projects, and we engaged OPDs, government, and we tried to, we worked with 9 government hospitals and 240 community clinics, which were equipped with leadership, medical professionals, and knowledge on disability to ensure diagnosis, treatment, rehabilitation, and referral services for people with disabilities. Under this initiative, we achieved 115 doctors and 242 frontline health workers were trained on disability inclusive services. These 9 hospitals improved their accessibility of health facilities, and we tried to establish the referral services from community to district level. And another important part of this component of this project was the engagement of organizations of persons with disabilities. We try to enhance the participation of disabled people and their organization in government health service delivery system through district and upazila level hospitals and community clinics. And if we hear from one community people that they shared in our focus group discussion is that now parents do not hide their children with disability. They want to treat their children. People do not try to hide their assistive devices anymore. Another intervention from this project was a national policy instrument for disability healthcare operationalized through government hospitals in district and upazilas. As we mentioned that the rehabilitation services is not always available at sub-district and community level. So that's why we try to implement and also advocate that these rehabilitation services are available at local level and sub-district level. So for this reason, we actually engaged and collaborate with different government authorities and also provided advocacy to influence government policies. And the last intervention that we will discuss is we try to increase awareness, knowledge, and understanding of disability and health and benefits of therapy and support services in family, community leaders, media, and policymakers and general public. So it is really important how we increase the awareness and knowledge on disability inclusion at different levels. So that was 4 major components of this project. And if we now look into the health model that we are talking about, so the health model actually looks like this, the model for quality and inclusive health for all. Here we can see that we worked with 9 hospitals at upazila level. We worked with persons with disabilities and their organizations, and we influenced government. These 3 major components we are trying to highlight through this Shibalaya Health Model. which was the key component of this model to reach the persons with disabilities at the community level and through the hospital at Upazila level. The rehabilitation support was provided to persons with disabilities, and we worked very closely with OPDs at the local level, and also we engaged government authorities at the local level, and we talked about disability inclusion in their services. So this is the health model, what we want to share with all of you. Now we would share some major findings of the evaluation that we have conducted. We have seen that the stigma around disability has been reduced in our working areas. People with disabilities and their caregivers became aware of the services and are satisfied with the quality of services. A total of 11,620 new patients with disabilities made 52,518 visits to the 9 Union Health Rehabilitation Centers. Government has provided a circular to all sub-district level health complex regarding the provision of accessibility. And government also committed to include disability data in national health MIS system. We have also found that as the services is at the doorstep of the community level, number of female patients has increased through this model. If one mother of a child with cerebral palsy from one of our working area, Chittagong, said that I used to take my children for regular therapy in a private therapy center in Chittagong city. Each sessions took 300 taka and I needed additional 200 taka for transportation. That time I could go only once in week, but now since this center started in hospital, I do not need any money for therapy and treatment. I expense only 50 to 70 taka for local transport and I can come regularly. So this is a reflection from a mother of a child that how this service at the sub-district level helped her to get the services for her children. There are a few recommendations that we want to share that we have found from the study. The meaningful participation of persons with disabilities and OPDs at different levels is key to create awareness and influence the implementation of government policies. Special attention should be paid to diverse groups such as girls, minorities, and people living in remote areas, because we know that it is really difficult for female and also different minority groups and also who are living in a very remote areas to get rehabilitation services at the district level. So special attention should be paid to different diverse group to provide that services. Regular training on disabilities and referral to doctors and other medical staff is required for quality services. OPD members or persons with disabilities can be identified and serve as champions to influence or advocate inclusive access to health and rehabilitation services. A follow-up system of referred patient could benefit them with who have multiple disabilities, like who have autism or cerebral palsy. The referral system can be more strengthened under this model. It could be beneficial for frontline staff of the government officials, including health assistants, family welfare assistants, health inspector, to receive training on disability identification, referral, and disability prevention. An advocacy mechanism should be strengthened for demanding the availability of specialized services, as these are not always the different kind of therapy like physical and speech therapy. These are not always available at the local level. So advocacy mechanism should be strengthened to, for demanding this type of services. Strong advocacy is needed to create cadre in government hospitals for technical rehabilitation personnel. So in Bangladesh, there is a lack of technical professionals like therapists. So government should create cadre in government hospitals for such type of technical rehabilitation. It would be helpful to create a child-friendly environment in the hospital so that the children with different disability can be stressed, can release their stress while they are in the hospital for taking different services. Collection of disaggregated data is important to provide health and rehabilitation services. And our final recommendation is government may mainstream Shibalaya Health Model, allocating adequate budget for accessible health and rehabilitation services. Yasmin has a physical disability. She is another program participant. She mentioned that after taking therapy, surprisingly, I noticed that I can move my hand and I started feeling that I can do something. So here is the photo of Yasmin, and we thank you all for listening to us. Any question or further clarification is welcome. Thank you very much.